Yes, I would like to sincerely thank Professor UOC for the introduction. Dear teachers and distinguished colleagues. Next, I would like to present the content related to lung cancer screening using biomarkers. The presentation covers 3 main points. First is an overview of lung cancer. Second is the importance of early diagnosis as well as the current status of lung cancer screening. And third are some current biomarkers that help us detect and screen for lung cancer early. And finally, some concluding points. As we know, lung cancer currently remains the disease with the highest incidence and mortality rates among all cancers for both genders. This is the 2022 GCK data. We can see that out of about 20 million new cases, lung cancer accounts for 12%, ranking at the top. And among the 9.7 million deaths worldwide in 2022, lung cancer also accounts for 18.7%. Thus, it is the disease with the highest incidence and mortality rate among all cancers for both genders. Looking at each gender separately, we see that in men, lung cancer ranks first in both incidence and mortality. And in women, it ranks second only after breast cancer. Clearly, the burden of lung cancer on us is currently very significant. A regrettable fact is that when we diagnose patients with lung cancer, the majority are diagnosed at a late stage. Even in developed countries like the United States, we see that the proportion of patients diagnosed at a metastatic stage is as high as 57%. And in Canada, we also see that lung cancer detected at stage 4 is approximately 50%, and at stage 3, it is 20%. So clearly, the disease is very common, and when detected, it is already at a very late stage. Therefore, we need to find a way to ensure we can diagnose it at an early stage. And regarding lung cancer prognosis, we also see that for patients who have already metastasized, their survival time is very short. In fact, we can see here it is measured in months. For many patients, it is only a matter of months. And the 5-year survival rate, even in the US at the 2 largest lung cancer monitoring sites, the CDC and SEER, is only about 4 to 7%. The point is that if we detect lung cancer at an early stage, we can help patients receive curative treatment with a 5-year survival rate that can reach over 90%. Conversely, if we detect lung cancer at a late stage, the 5-year survival rate is still very low. Even with stage 4B shown here, we see that less than 1% of patients can survive after 5 years. We will move on to the second part that I want to share with my colleagues, which is the importance of early diagnosis as well as the current status of lung cancer screening. For a long time, the World Health Organization has proposed a lung cancer screening model for how we can diagnose patients early. Even before tumors have formed, we already have plans to evaluate risk factors. And when tumors have formed, or when we can detect them using diagnostic imaging methods, how can we arrive at an early stage diagnosis? And they have also established many specific criteria for biomarkers to help with early diagnosis as well as lung cancer screening. For example, here it is divided into 3 biomarker groups. First are the groups that help us assess risks. When cancer has not yet formed, we can use biomarkers to help detect genetic abnormalities or individual risk factors, so that we can predict the risk of cancer developing in the future. This is the group of biomarkers used for risk prediction. The second type is for cancer detection, meaning the cancerous lesion already exists. However, if we cannot detect it yet using diagnostic imaging methods, this group of biomarkers will help us determine whether cancer is present or not. And finally, the third group is biomarkers that assist in diagnosis. When we have already detected lung nodules or masses, but we do not yet have a confirmed diagnosis, or for some reason our patient cannot undergo diagnostic procedures, these biomarkers will help determine whether that lung lesion is benign or not. Thus, we can see the role of biomarkers in screening as well as early diagnosis of lung cancer, which is predicting the risk of developing lung cancer or helping us distinguish between a benign or malignant lesion. Researchers have also proposed criteria for a good biomarker to help screen for lung cancer. The method must be easy to perform. Secondly, it must pose low risk to the patient with minimal invasiveness. Thirdly, it must help us detect whether a lesion is benign or malignant. And finally, the cost must be low and it should be widely applicable. These are the criteria set forth to ensure we find a truly effective screening method. Regarding the current situation, there are several methods used for early diagnosis as well as for lung cancer screening. The first is the use of routine chest X-rays combined with sputum cytology. This is perhaps a very simple method because we can perform routine chest X-rays at all medical facilities today at a low cost. However, through large studies, it has been found that this method, even when combining routine chest X-rays with cytology and sputum examination, is not very effective. It was found that it only detects about 20% more cases with dual screening, but the final outcome is that it does not change the mortality rate of the cancer. Secondly, there is screening using computed tomography. It is clear that we know computed tomography detects lung lesions better than X-rays, but our patients have to be exposed to very high radiation levels. And by using low-dose computed tomography, it can help reduce the radiation dose down to about 10 to 20%. And nowadays, we even have ultra-low-dose computed tomography, ultra-low-dose CT, with a radiation dose similar to an X-ray film. And through recent large trials, such as the Nelson trial or the UKLS trial in the UK, we see that current practice guidelines from the World Health Organization and cancer societies worldwide have implemented lung cancer screening programs for high-risk groups. That means smoking for 20 years or more, aged from 50 to 80. And in some recent guidelines, they have added criteria. For example, if one has immediate family members who have had lung cancer, they can also be included in screening. Next is bronchoscopy. Bronchoscopy can help us evaluate changes in the airway mucosa. Here, we mainly talk about early-stage diagnosis. As for using bronchoscopy to help with cancer screening, it is not mentioned. And with image-enhancing technologies, such as using fluorescent light or narrow-band imaging, it helps us detect early changes on the bronchial mucosal surface so we can diagnose cancer in its early stages. The advantage of bronchoscopy is that it is only intended for central tumors, which are often accompanied by bronchial mucosal lesions. As for peripheral cancers, the bronchoscopic image is usually normal. And in recent years, we have been hearing and talking a lot about a method called liquid biopsy. What is a liquid biopsy? It involves using molecular biology methods to detect components of cancer cells in the blood. And liquid biopsy currently plays a major role in the comprehensive diagnosis and treatment of cancer. It covers screening, diagnosis, cancer assessment, as well as choosing personalized treatments by detecting gene mutations and immune abnormalities, and even monitoring cancer. Now, we will move on to the most important content of this presentation, which is the role of biomarkers in the early detection and screening of lung cancer. Here, we mention 5 biomarkers currently being used for the screening and early diagnosis of cancer. First are microRNAs, second are antibodies, and third are circulating tumor cells. Fourth are exosomes, and the fifth, most importantly, which we are discussing a lot these days, is ctDNA. First, regarding microRNAs, we know that they play a role in regulating gene activity, and alterations in microRNAs have been proven to be strongly linked to the onset and progression of most types of cancer. And for lung cancer, many microRNAs have been recorded as being related to the onset and development of lung cancer. And thanks to molecular biology methods like RT-qPCR, we are now able to detect microRNAs in serum. This is a method that I believe is very promising, as it detects them in the blood at a very early stage of cancer and could soon become a biomarker for lung cancer screening. Currently, some companies have developed kits that help us detect the 9 most common microRNAs associated with lung cancer, with a sensitivity of up to 80% and 100% specificity in patients already diagnosed with cancer. Secondly, regarding antibodies, we know that cancer cells are antigenic and stimulate the body to produce antibodies, and many cancer-related antibodies have now been identified. Researchers are also developing kits to detect these antibodies with the goal of enabling early cancer detection. However, current techniques for detecting cancer-associated antibodies have relatively low sensitivity and relatively low specificity. I think that in the future, with better antibody detection methods, it may be possible to identify these antibodies at an earlier stage. Third is circulating tumor cells, CTCs. We know that CTCs are cancer cells that migrate into the bloodstream during the progression of cancer. There are currently many different techniques that allow us to detect CTCs in circulation, including methods like cell search or ISET. However, a challenge is that CTC detection depends heavily on the stage of cancer progression as well as the type of cancer. We know that the later the cancer stage, the more cancer cells are in the bloodstream, and for small cell cancer, the ability to detect them using circulating tumor cell detection techniques is higher. Next are exosomes. We know that exosomes are small extracellular vesicles, ranging from about 40 to 100 nanometers in size, released by cells into body cavities, including cancer cells. Within these exosomes, researchers have found DNA, mRNA, and, notably, microRNAs related to tumors. Currently, studies are developing exosomes as potential biomarkers by analyzing these microRNAs, and some roles for exosome testing in screening and evaluating tumor growth and progression have already been recognized. Finally, I would like to share with my colleagues a marker that I consider very important, which is ctDNA. ctDNA refers to DNA fragments originating from tumors that are released into the bloodstream. Currently, we have techniques, especially next-generation sequencing, that allow us to detect ctDNA in the blood at very low thresholds. And we know that ctDNA can be released into the blood at every stage of cancer's biological progression. As soon as cancer cells appear, they undergo cell death cycles and release ctDNA into the bloodstream. Therefore, detecting ctDNA in the blood can allow for cancer detection at an early stage, making it applicable for early diagnosis and screening. It has also been observed that the concentration of ctDNA in the blood correlates with the stage of tumor development. At early stages, this concentration is still low. With conventional techniques, it is more difficult to detect. However, by applying new techniques today, such as digital PCR or droplet digital PCR, and especially next-generation sequencing technologies, we can detect ctDNA concentrations in the blood at very low levels, which is an advantage for lung cancer screening. Regarding the advantages of ctDNA, we can see that it is a non-invasive method. Our patients only need to provide a blood sample, and advanced techniques will help analyze whether that blood sample contains ctDNA related to the development of lung cancer cells. And with current techniques, we have already achieved quite a high level of accuracy. We will look at these techniques shortly, and at the same time, ctDNA can inform us if our patient has various types of cancer. Regarding the challenges of this technique, it is observed that in the early stages, the concentration is low. Therefore, it requires specialized methods for us to be able to detect it at such very low concentrations. Secondly, tumors possess a high degree of genetic heterogeneity. What does that mean? It means that the same tumor can carry multiple genetic abnormalities, and many different tumors can share the same genetic abnormality. Therefore, we need techniques to be able to distinguish which specific cancer type this ctDNA abnormality is associated with. And currently, we have also made progress in lung cancer screening based on ctDNA by using next-generation sequencing techniques combined with artificial intelligence. We input the ctDNA abnormalities. After that, thanks to artificial intelligence, we build databases to generate analyses, and gradually this system will become increasingly better at analyzing specific markers for different types of cancer. And what is the situation regarding the application of ctDNA worldwide and in Vietnam? Since 2016, ctDNA has been included by the NCCN in clinical practice guidelines for non-small cell lung cancer treatment. By 2022, ctDNA was approved by the FDA to survey gene mutations to support targeted therapy in cancer. By 2024, ctDNA was approved by the FDA as one of the methods for colorectal cancer screening. And at the beginning of this year, ctDNA was officially included by the NCCN in standard cancer screening practices. And this is truly a revolution for us in the issue of cancer screening in general and lung cancer in particular. And we can see on the map of cancer screening markers today, Vietnam also has a test called Spot Med that helps us detect 10 basic types of cancer. And these Spot Med tests have now been approved by the Vietnam Ministry of Health for clinical use. And there is a test that has just been licensed by the Ministry of Health, which is Spot Lung, specific for lung cancer. This is a liquid biopsy test that detects cancer by analyzing ctDNA characteristic of lung cancer, and it has also integrated artificial intelligence for analysis. And it helps the technique achieve a high sensitivity of 90% and a specificity of up to 92%. And the current cost is also relatively low compared to us having to send gene analysis samples abroad. So, through my presentation just now, I would like to offer a few concluding points as follows. Lung cancer screening is extremely important. It helps us detect the disease at an early stage, as well as select effective treatment methods and provide a better prognosis for patients. Biomarkers are a potential trend for screening and early diagnosis, and can simultaneously help distinguish between benign and malignant lesions. And ctDNA analysis based on next-generation sequencing combined with artificial intelligence will be a potential solution and a new direction in cancer screening. Today, my presentation ends here. I would like to sincerely thank the distinguished teachers and colleagues for listening.